Welcome to our third UMD-PRC webinar series. We are incredibly excited to have Dr. Christi McGeorge here today to talk with us about beliefs about referring LGB clients, exploring unethical clinical practices. We just want to remind everyone, for the purposes of today, we are recording the webinar. Although this isn't a webinar format, you should not be able to share your video or audio, but just want to give that warning that we are recording today. So please feel free, if you're not comfortable with that, to log off. We're also offering closed captioning available through Zoom's automatic live captioning feature. So you can activate this in your settings if you'd like to have closed captioning as you follow along with the webinar. At the end of today's webinar, we will also be doing a Q&A session with Dr. McGeorge. So please feel free to put your questions in the Q&A box as the webinar progresses. And at the end, all are listening to today. So with that, I just want to transition and welcome Dr. Christi McGeorge to our webinar series. We're incredibly excited to have her. She is a professor in the Department of Human Development and Family Science at North Dakota State University and has worked at NDSU since 2003. She earned her master's in Human Development and Family Science from Colorado State University and her PhD in Family Social Science from the University of Minnesota. In her position at NDSU, she has had the opportunity to mentor undergraduate and graduate and doctoral students. Many of them go on to do this important work for the rest of their careers. And Dr. McGeorge is passionate about research and particularly enjoys helping students develop their own excitement and passion for research. I've been a big fan of Dr. McGeorge since I was a student myself and really excited to hear her speak today. So her research is focused on the influence of heterosexism and cissexism and sexual and gender minority prejudice on clinical practice and training, gender equity in therapy, promoting LGBTQ ally behavior in collegiate athletics, gender equity in higher education, and societal perceptions of single parents. And we are particularly excited to hear about her work on the ethical considerations of referral and change efforts today. So without further ado, Dr. McGeorge.
Thank you so much. I want to thank both Jessica and Hannah for all their hard work in putting this webinar on. I know there's lots of logistics involved in these sort of sessions. A couple of notes before I begin my presentation. Fix some things for me. Sorry, a couple of notes before I begin my presentation. Today I will focus on those with a marginalized sexual orientation. And thus you will not hear me talk today about those with a marginalized gender identity. Often in my research, in order to honor both sexual orientation and a gender identity as distinct components of who we are as people, I do my research on sexual orientation and gender identity often separately. I don't do this in any way today to further marginalize those with a transgender, non-binary, or genderqueer identity. But do know that I'm replicating all of these studies you'll hear about today, focused on gender identity, and would be excited to also share that data with you in the future. In particular, today I'm going to talk about what I see as one of the predominant ethical issues related to working with LGB clients that is at the forefront of social and political and professional discourses. That's the referral of LGB clients based solely on their sexual orientation. We have seen discussions of this in the political arena as we see conversations about religious freedom bills, consciousness clauses. And so I'd like to really examine this. Today, I'll be looking at this issue from three perspectives: from the views of practicing clinicians, from the views of faculty members who are tasked with training the next generation of clinicians, and from the views of religious leaders. And that third sample will make more sense. That third study will make more sense as we get into the data. So first, what are therapists' beliefs about referring LGBT clients? The current research suggests that therapists are becoming increasingly affirmative in their work with LGBT clients. I'm not suggesting we have arrived. There's much work to do to increase the affirmative and inclusive nature of clinicians. But we are seeing a trend towards therapists becoming more and more affirmative to some extent. But there continue to be therapists across disciplines who refuse to work with LGBT clients based solely on their sexual orientation, while refusing to work with other marginalized groups, whether we talk about women, people of color. We could come up with many other examples. Is no longer seen as an acceptable practice by the therapeutic community. For some reason, it seems that refusing services to the LGBT community is still considered acceptable by some therapists. To explain, 741 clinical members or clinical fellows of the American Association of Marriage and Family Therapy. This sample of clinicians was gathered with intentionality to gathering geographic diversity, and I'd be happy to answer questions about how we did that. But the sample ranged in age from 27 to 79 years, with a mean age just over 54 years. The majority of the sample was women, white, and heterosexual, which reflects the makeup of the clinical fellows of AMFT. The participants had 2 to 54 years of postmaster's experience with a mean of just over 19 years. And just over 66% of the sample reported working with 30 or fewer lesbian or gay and bisexual clients throughout their clinical careers. I utilized an online survey. There were 2 surveys that comprised my larger questionnaire. The first was the Modern Homophobia Scale, which was created to evaluate beliefs about sexual orientation, specifically looking at personal biases that clinicians or any individual might hold. It's comprised of 46 items, and responses varied from 1 strongly agree to 6 strongly disagree, and it showed really good internal reliability. The second scale is the revised clinical counselor competency scale, which was created to assess overall perceived clinical competence to work with LGBT clients. While the RSOCCS, for those who might be familiar with it, is comprised of 2 subscales, this study only utilized the knowledge skill subscale, which is that measure of competence. The knowledge skill subscale had 16 items, and again, range from 1 strongly disagree to 6 strongly agree. Now, we also used 2 dichotomous questions. We asked these clinicians, is it ethical for a therapist to refer a client based solely on the client's sexual orientation? And also, have you ever referred a client based solely on their sexual orientation? So let's look at some descriptive findings. What did we learn from these therapists? First, we found that almost 62% of the sample believed that it was unethical to refer LGBT clients or to refuse to work with LGBT clients. However, that means nearly 29% of the sample thought it was ethical. Now, there's something interesting on this slide in front of you. You notice I reported the missing data, or those that did not respond. I would say on the whole, this questionnaire had people skipped items or didn't respond to items. About 1% of all items were missed, which is pretty typical for the surveys I do. But with this question, 10% of the sample didn't answer the question about whether it was ethical. And for me, while I know I don't know for sure, that is also data. That tells me something about maybe there were more people, potentially. One potential is that there were more people that thought this was an ethical behavior, but they didn't want to say so. When asked if they specifically themselves had referred an LGBT client, 7.3% of the sample said they had, but over 4% also skipped that question. Again, we don't know for sure, but it's worth thinking about. In terms of their overall competence, the RSOCCS knowledge skill subscale ranges from 1 to 6, with higher values on the subscale being associated with greater self-reported clinical competence. This sample reported a mean level of clinical competence at 4.2. So they're reporting a moderate level of competence, but we see that there's a good size standard deviation and a decent size range there. With the modern homophobia scale, here, higher scores represented increased levels of negative behaviors or increased levels of homophobia. And we see that our sample reported a mean of 1.88, so rather low homophobia. And we see, but again, a rather large range in standard deviation. So right now we've got about 30% of our sample saying it is ethical, and somewhere between 7 and 10% of our sample having engaged in referral. We wanted to do some further analyses to see if clinical competence and homophobia predicted people's beliefs and whether they had actually referred. So what did we find when we did some more statistical analyses? We found that clinical competence was not a predictor of therapists' beliefs about the ethics of referring. Now, this wasn't entirely surprising, given the multiple reasons why therapists with both higher and lower levels of clinical competence might see such practices as ethical. So, for example, a therapist with a high level of clinical competence working with LGBT clients may prefer that another therapist refer LGBT clients if that other therapist is likely to provide incompetent services. And this could come out of concern for the well-being of LGBT clients. On the other hand, therapists with relatively low levels of LGBT clinical competence might perceive such referrals as ethical because of their own desire to avoid working with this population. And so there's a number of things going on there. However, it's important to note that lower levels of clinical competence were a significant predictor of having referred an LGBT client. We're going to talk more about this as we look at the next study. But this really raises this question about clinical competence an ethical reason for refusing to work with an entire population of clients. And so we're going to explore this better with the next study. Now, what did we find when it came to homophobia? Well, that homophobia was a statistically significant predictor of both believing it was ethical to refer and having referred an LGBT client. So individuals who believe it's ethical to refer LGBT clients, even if they hadn't done so themselves, still reported higher levels of negative beliefs about LGBT individuals and relationships. Probably this finding is not surprising either, as many researchers have documented that therapists' personal values directly influence their clinical decision-making. While the influence of personal values on the therapeutic process is well established in the literature, this was the first study to find that negative beliefs, that homophobia, directly impacts clinical decision-making as it relates to referral or the refusal to see LGBT clients. So this was the first step. But now we're going to take another step that I think will give us better insight into this dynamic. So the second study focused on faculty members, again with the idea that understanding faculty members' beliefs are important because they are tasked with socializing and training the next generation of clinicians. For this study, we surveyed 117 faculty members from accredited couple and family therapy programs. These participants ranged in age from 29 to 73 years, with a mean age just over 47 years. They had been faculty members for 1 to 40 years, with a mean of just about 11 years. Again, the majority of the population, though there was better diversity in this sample, identified as women, heterosexuals, and white. Again, the percentage breakdown of those things did reflect at the time the current breakdown of faculty in these accredited programs. 54% of them were working in master's only programs, 4% in doctoral only programs, and about 32% in dual master's and doctoral programs. And just about 89% of them reported working with an LGBT individual or couple in therapy themselves. We again utilized an online survey And today I'm going to focus on 5 Likert scale items that assess faculty members' beliefs about the ethics of the practice of referring LGB clients. These 5 Likert scale items were on a 6-point Likert scale ranging from strongly disagree to strongly agree. I'm also going to report the data from an open-ended question we asked all of these faculty members, and it was this: under what circumstances, if any, is it ethical for a therapist to refer a client based solely on the client's sexual orientation? So we're going to start first with the results of the quantitative data and just looking at descriptive statistics for our time today. And then we're going to delve into some of the qualitative data and what our analyses showed there. So I'm going to show you a series of tables. I hope that you're on a screen where this comes through well enough. But overall, the results of the 5 Likert scale items associated with the ethics and practice of referring LGBT clients based solely on the client's sexual orientation found that the majority of the faculty members surveyed did not support this practice. But there's some exceptions that are important to know. But let's take each of these items individually. In particular, the first item, which asked faculty members if they personally believe that it's ethical to refer a client based solely on the client's sexual orientation, revealed that 16.1% agreed to some extent with this item. However, 46.4% strongly disagreed that it's ethical to make such a referral. The second item explored faculty members' beliefs about whether or not it's consistent with the AMFT Code of Ethics for a therapist to refer based solely on the client's sexual orientation. And 77.5% disagreed to some extent, with 40.5% indicating that they strongly disagreed with this item. The third item asked faculty members if they believe students should be allowed to choose not to work with LGBT clients based on their own personal and religious beliefs about sexual orientation. For this item, 33% agreed to some extent, with 9% strongly agreeing. Let me say that again. So 33% of the faculty surveyed agreed to some extent that students should be allowed to choose not to work with LGBT clients. And so this raises a question for us to explore. Again, we had just about 9% of people strongly agreeing. I'm going to add 2 more pieces to this discussion from the quantitative findings. The fourth item explored the extent to which faculty members teach their students that it's ethical to refer based on a client's sexual orientation. And 20.3% agreed to some extent. So 1 in 5 of our participants agreed that it was ethical to teach students that it was ethical to refer based on the client's sexual orientation. However, conversely, 79.6% of the faculty members surveyed disagreed to some extent, with 35.4% strongly disagreeing that they teach their students that it's ethical to refer a client based solely on sexual orientation of that client. Finally, the 5th and last item asked faculty members if students in their programs are allowed to choose to not work with LGBT clients based on the students' personal and/or religious beliefs about sexual orientation. The results indicated that 26.3%, so over 1 in 4, agreed to some extent with this item. So we see why the majority of faculty seem to be communicating that the practice of referring all LGBT clients or refusing to work with them is not ethical. There's a group of faculty who do believe it's ethical and are teaching their students accordingly. So let's take a look at the qualitative data. What did we find out when we asked them, under what circumstances, if any, is it ethical to refer an LGBT client? The most common response is reflected in theme 1. And that theme said, under no circumstances. Some of the quotations that illustrated this theme include: never. It's unethical to discriminate based on sexual orientation. None. I don't think it's ethical at all. It's the therapist's responsibility to be a good therapist, and under no circumstance. This theme contained one sub-theme, which was they shouldn't be therapists. You see the quotes illustrating this sub-theme on your screen, but I'll take a moment to read them to you. None. Therapists who can't uphold the code of ethics and their ability to work with diverse clients should not be in the profession. And family therapists who can't work with clients due to the biases relevant to sexual orientation should not practice. The second theme focused on the idea that therapists may do harm. Examples of the responses coded in this theme include: if a therapist will do harm to a client based on the therapist's heterosexual bias, it's ethical for the therapist to refer the client. It must also be noted that the therapist is acting unethically by being heterosexist. There was one sub-theme identified within this theme, and that was an obligation to do self-work, which is illustrated by the quote that you see in front of you. If a therapist is uncomfortable with working with a specific population, referring a patient is not the answer. The therapist must educate him or herself on working with the population and seek supervision or consultation to improve their work in this area. The third theme, representing the third group of responses related to the ethics of referring, focus on a lack of competence and training. The following quotations illustrate this theme: true incompetence and incompetence as an excuse or denial of specific training. If someone sought therapy to specifically address coming out or something highly specific to sexual orientation, it would be appropriate for the therapist to refer if they felt they were practicing outside their area of competence. There is one sub-theme also identified within theme 3, and that was scope of practice. Perhaps if the therapist feels out of their scope of practice of expertise, then they should refer, or if the presenting problems are out of the clinician's scope of competence. I'm going to talk more about this idea of scope of practice and competence after we review the remaining themes. I think this will be an important discussion for us to have today. The fourth theme, therapist beliefs and biases, was illustrated by the following responses. If the therapist has too much deep homophobia or religious beliefs that purport that GLB persons are choosing this and are having or have morality views, the environment cannot be supportive. It is crucial that the client be referred out. When the therapist can't rise above her or his own bias and provide quality services to the client, in such cases, she or he is doing harm, which is highly unethical. And finally, if the therapist's beliefs and biases are so entrenched that the belief and biases would lead to abuse and neglect or harm to the client. Within this theme was one sub-theme. It entailed a series of responses that were about the right to refer a client, as illustrated by the quote on your screen. When the therapist knows convincingly that she or he can't provide quality services to GLB clients without bias, I question whether it's about ethics. However, some individuals' faith tradition is opposed to GLB. Is it ethical to insist that such a therapist work against deeply held religious beliefs? I don't think it's wrong. The fifth reason our participants identified was related to client request. The following quotations are kind of indicative of this theme. If the client requests it, if the client is uncomfortable working with a therapist based on the therapist's beliefs regarding sexual orientation, and the only time I could see it is at the request of a client, any other time you are breaking other parts of the code and you open yourself up for human rights complaints. Within this theme, there was also one sub-theme, which is prefer LGB or affirmative therapist. If a GLBT client states that they would prefer having an openly gay or openly affirming therapist, or if the client is a therapist who is themselves gay or claims a specialty in LGBT issues. The sixth and final theme that we identified within our qualitative data with these faculty members was related to the AMFT Code of Ethics. And this theme encompasses faculty's responses about the ways in which the AMFT Code of Ethics addresses or fails to address the practice of referring LGBT clients. There were two sub-themes identified within the data coded under this sixth theme. The first sub-theme was that the AMFT Code of Ethics supports referral. Although it seems a cop-out, a therapist could say that she or he does not have competence in that area, and AMFT would not have to have us work outside our competency. So we see competency coming up again. And then the second sub-theme was that the AMFT Code of Ethics is ambiguous or contradictory. The AMFT Code of Ethics is deliberately ambiguous and therefore not LGBTQ affirmative. So given all of this data, both the quantitative and qualitative data, what is this study telling us? Well, we see they express less certainty about the ethicality of referring clients based solely on sexual orientation. The vast majority felt that referring a client was unethical, but 1 in 3 faculty members believe that students should be allowed to choose not to work with LGBT clients based on their own personal and or religious beliefs about sexual orientation. One of the common rationales provided by faculty in this study was that therapists could justify referring if working with LGBT clients would be outside their scope of practice or clinical competence. In particular, some of the participants referenced the AMFT Code of Ethics, as we just saw, as supporting this particular justification for refusing LGBT clients' clinical services. The notion of referring an LGBT client based on scope of practice is problematic, as it suggests that a group of people based solely on demographic factors, based solely on identity factors, could fall outside the therapist's scope of practice. Based on this rationale, and I'm going to be offensive here for a moment, and I apologize, I don't mean these words, but based on this rationale, therapists could make the argument that all Black clients were outside their scope of practice and therefore refer based on the client's race, and therefore a referral based on the client's race would be deemed appropriate, which clearly would be unethical and is clearly inappropriate. Similarly, to suggest that a referral based on demographic factors alone is appropriate due to a lack of clinical competence with an entire group of people infers that clinical competence exists on the level of group identity as opposed to the problems that clients present with in therapy. Additionally, when applied to LGBT clients, this could mean that a client's LGBT identity is viewed as the presenting problem instead of it as existing as one of many characteristics that define a person. Moreover, referring all LGBT clients based on a lack of clinical competence suggests that it's acceptable for therapists to lack competence in an entire group of people. However, scholars have argued that therapists should be able to work with all clients, regardless of demographic factors, and that therapist clinical competence should be based on presenting problems and treatment modalities. This data also raised the question about religious beliefs and the role that religious beliefs play in the decision to refer or refuse to provide clinical services to LGBT clients. And so this led this researcher to interview a group of participants that maybe I had never envisioned, as someone whose career has been research career has been focused on LGBTQ affirmative and inclusive therapy practices, I maybe didn't envision that one day I'd be interviewing a group of religious leaders. But I realized that there was voices that needed to be added to this conversation, and that while I had been trying to talk to my fellow therapists about this idea of the unethicalness, I don't know that that's a word, sorry, of referring all LGBT clients, I didn't have the authority or the theological knowledge maybe to make the argument that they needed to hear. And so that led me here. Because with therapists report an unwillingness to work with LGBT clients, we've seen this in data over and over again. So when therapists report an unwillingness to work with LGBT clients or a pattern of referring LGBT clients based solely on their sexual orientation, they frequently cite their own religious beliefs as a rationale. And scholars, like myself, have not engaged Christian pastors about their perspectives on referring LGBT clients in order to explore the religious element of this practice and to contribute to the literature by expanding this conversation to include the insight of Christian pastors who may have unique knowledge of the consequences of therapists referring LGBT clients for religious reasons. In this study today, I did focus on Christian religious leaders. To be honest, my own discipline, couple and family therapy, is vastly comprised of clinicians who identify as Christian. We're the most Christian mental health discipline that exists. And so I decided to start there. I'm in the process right now of replicating this study to focus on gender identity, and then we'll replicate again to expand to other religious and spiritual traditions. But today, I will be talking about interviews with 21 Christian pastors from diverse religious traditions, including Lutherans, Methodists, Episcopals, Presbyterians, and United Church of Christ. The pastors that I interviewed, I and my colleague Caitlin Coburn interviewed, ranged in age from 30 to 70 years, with a mean age just over 50. They had worked as pastors for 18 months to 43 years, and on average had worked as pastors for about 16 years. The sample was comprised of 10 cisgender women and 11 cisgender men. 3 of the men participants identified as gay. All but one of the participants identified as white, and all of them were working in either urban or rural upper Midwestern communities in the United States. We used a queer theory-informed phenomenology as our methodology for this study, and put together a semi-structured interview protocol. The interviews were coded using thematic analysis, and we took a number of common and sort of unique steps to ensure the trustworthiness of our data. I'd be happy to talk about that if that's of interest to anyone during the question and answer period. But I'd like to spend our time looking at what the pastors had to share. I'm going to divide up this data around 2 issues. We're going to talk about their perceptions of this practice of referring LGBT clients, and then I'm going to talk about their advice for therapists. So the first 3 sets, the first 3 themes and sets of quotations are all focused on pastors' perceptions of the practice of referring. The first thing I want to talk about is we named in the best interest of the client and the therapist. And I've got 2 quotes to illustrate that. I'd be thankful for the honesty in making the referral. I mean, if someone is seeking a therapist, I wouldn't want them to work with someone who fundamentally has a conviction that is antithetical to who they are as an individual. While it's sad, it might also be helpful for the person receiving therapy to know that up front. And a second pastor shared, if they're refusing to see LGBT clients, that's their right. They can refuse, of course, not my issue. That's their issue. And if they ask me further, I'd say, well, you're going to have to appear before the throne of God one day, and let me tell you, you probably are not going to like what you hear. So why the pastors noted a similar concern to what we saw from the faculty, that potentially it was in the best interest of the client if they didn't work with therapists who held negative beliefs. you see, as reflective of other quotes, not shown here, but that I could show you, you see there's some concern. This idea of best interest still comes with some awareness from these pastors that this isn't okay, which reflects theme number 2. While we certainly as researchers didn't introduce the idea of discrimination or discriminatory practice because we wanted to see what these pastors would say, they were quick to label this practice as a discriminatory practice. I'll give you 3 examples. One pastor said, it's abusive if you're using your religion to discriminate. A second, when you enter the public sphere, when you do business in the public sphere, you agree to abide by certain rules. And one of those rules is that you will do business with who comes in your door. And if your consciousness gets in the way, then you have to exit that public sphere. And a third pastor shared, I think that one more rejection from any person, especially a professional who they are reaching out to for help, is horrifying. And for me, almost unfathomable. I know that it happens, but it's not my experience. That's privilege for me. I can't imagine that kind, again, the level of harm that we're doing. It's irreconcilable. This was the most common response when we asked pastors about this practice. I didn't know what response we get when I sat face to face with pastors and asked them these questions. But here you see this clear concern. The third and final theme about the perceptions, about the pastor's perceptions and the practice of referring was named "No referral will be provided." Again, I'll share 3 quotes. The first, they will get knocked off my referral list pretty quickly. For folks I would refer anyone. I wouldn't refer them to any of my congregational members after that, if that's what I heard, because quite frankly, the human person is layered and difficult and challenging, and all of that is affirmed by God, except they can't accept that small part. The big struggle that comes with that is how else are you not listening in love, which is part of the job. I would take them off my referral list. And the second pastor shared, if their beliefs are going to make them exclude someone, I have concerns about that. I have concerns about how they can be therapeutic to any other person, because a lot of therapy has to do with the patient being accepted by the therapist. And then finally, another therapist, a third religious leader said, I think the 2 positions that have the greatest risk of damaging a person by breaking trust are therapists and pastors. So turn in your license if you're for LGBT clients, go work at Jiffy Lube or something. I asked this pastor why she thought they should go work at Jiffy Lube. And she explains to me that that's where she takes her car to get its oil changed. And the mechanic that changes her oil, she realizes she has no contact with. She talks to someone at the front desk, but never talks to the mechanic at who changes her oil. And she felt that if someone held these sort of negative beliefs about LGBT people, that they shouldn't have contact with any person. So she insisted on Jiffy Lube. And when she reviewed this presentation, insisted that I keep the Jiffy Lube quote. So we then asked the pastors about their advice. What did they think therapists should do? What would they want therapists to know who are engaging in this practice of refusing clinical services to LGBT clients? And again, we ended up organizing these responses also into 3 themes. So the first theme in terms of advice was this. Well, if therapists were going to refer LGBT clients, then they need to develop a well thought out referral plan. This first quote illustrates one of the pastors role playing the best way they thought someone could say this. I think a counselor could say, this is something that may be a little out of my depth, but I think this person would be a great fit for you. I think that if it was framed in that kind of language, it can do more good than harm. It could do good and less harm. Another pastor said, that they, therapists, better have a really good list of referrals of people that will see that person. The second theme focused on pastors' advice that therapists need to be accountable for their own beliefs. So be accountable for your own beliefs. This religious leader said, you have to own your own shit. They have to own their own stuff and perhaps look at how their theology plays out in the world. What are the consequences of that theology? That might be another piece of advice I would give them. And a second pastor said, therapists deal with this all the time. You can separate your own family upbringing or whatever from what that person, that client is dealing with. I mean, on a certain level, that's often challenging to do because we all have buttons, we all have issues that may be harder to deal with, but the job of a therapist is to be a neutral person. And then the third thing, pastors said that they would like to invite therapists to engage in conversations with them. So these pastors envision that would be helpful for therapists to talk to them. And this is in particular what they said. One pastor said, well, do you want to talk to me about that so that you realize that you can talk to them about this? A second pastor said, it would be really interesting to engage in a conversation of how that act of referring all LGBT clients reconciles with Jesus' commandment for us to care for all of our neighbors and with Jesus' commandment to love the least and the lost and to reach out. So it would be a really interesting conversation. How are we reconciling what it looks like to be in the world and not of it? A third pastor said, I would challenge them. Why? I mean, it's a psychological thing, whatever the presenting problem is that they're dealing with. I would challenge them to realize you have to turn them, LGBT clients, away just because it's a religious thing. They need a therapist too. So from talking to these pastors, the findings of this study support existing research and further illuminate the need for therapists to consider the impact of referring LGBT clients based solely on the client's sexual orientation, and for professional associations to develop a formal stance on the ethics of referring LGBT clients to prevent discriminatory referrals. The pastors in this study highlighted that therapists should evaluate any non-affirming religious beliefs that lead to a refusal to work with LGBT clients in order to avoid harming LGBT clients by potentially becoming another source of rejection in their lives. The findings resulted in several suggestions for therapists, including developing a thoughtful referral plan and engaging in conversations with pastors to work through religious beliefs that prevent the therapists from working in an affirmative and competent manner with LGBT clients. Therapists are in a position of privilege and therefore are charged with the task of providing competent and affirmative services to clients with diverse identities. Ultimately, we hope that this study encourages therapists who refer LGBT clients to engage in self-therapist work and to seek out the resources of religious leaders in order to reach a realization that sexual orientation is an element of a client's identity, and rather than viewing it as a reason to refuse therapeutic services. I'm going to stop at this point and thank you for listening, and I'm excited to hear and welcome your questions.
Fantastic. Thank you so much, Christi, for presenting that work that is quite comprehensive across those kind of three different groups. I do welcome questions in the Q&A. We'd love to hear from our participants about what they're thinking, some reactions or questions in particular that Dr. McGeorge can answer. I know for me, I have a few things maybe I can ask in the meantime while we're waiting for folks to offer some questions up. But your comment about AMFT as being perhaps one of the most religiously affiliated mental health, if not the most religiously affiliated organization, thinking through some of the statistics that you presented on the their beliefs on ethics of referral in particular. How do you think, or maybe there is research about how this stacks up to other mental health organizational professionals, whether that's MSWs or licensed psychologists, things like that? Can you talk about and contextualize AMFT vis-a-vis these other professional organizations?
Most definitely, and I should clarify something. I will say that couple and family therapists or marriage and family therapists, depending on how you name the profession, are the most Christian secular group. So of course we could talk about pastoral counselors and Christian counselors, obviously very different. So I don't want to misrepresent that. Unfortunately, this idea, I think, of what is often labeled the discriminatory referral in the literature, this referring of LGBTQ, we could really expand out now our conversation, even though my data that I presented today was just focused, but these discriminatory referrals with LGBTQ clients happen across the disciplines. And some of the disciplines are starting, some of our professional associations are really starting to address them and define what a discriminatory referral is. I will say, for instance, the National Social Work Association has made some statements. Many of the associations, even though there were some good guidelines around working with LGBTQ clients, hadn't addressed this specific issue. And so there's not a lot of data out there at this point. There were some studies in the early 2000s based in psychology and counseling looking at this trend, but I have to think that it's improved in terms of there are fewer referrals happening. But what that research does tell us, and then the studies that I've now done show that it is happening across mental health disciplines. However, this idea of needing a religious exemption, or like, as long as it's my deeply held, and this is what these state laws say, if it's my deeply held religious beliefs, I don't have to practice against it. It raises some significant questions, though, about who we're protecting. So these laws are about protecting clinicians, not about protecting clients, and who is harmed by this. And we know that these referrals, both from data, and probably each of us have some anecdotal stories for having met LGBTQ clients who've experienced these refusals. We know this immense harm they cause.
Absolutely. And I think about for those that are potentially in rural spaces where it's not easy to access lots of options for therapeutic services, that could potentially negate your only option for therapeutic service. Yeah.
And I think I really appreciate you highlighting that, Jessica, because I think that's a particularly important point. Is this idea that referrals are okay are also based on the notion that there are referrals to make, and that those referrals don't involve undue burden on the client based on increased cost or increased need for travel. However, I'm going to argue that there's not even if I have a referral next door I can give you, the question has to be about my right to get to be a therapist, because being a therapist is a privilege, not a right, actually. It's a privilege. And all of our mental health associations, no matter where they are in taking a stand on discriminatory referrals, all of them have a non-discrimination clause. And you can't tell me that a pattern of refusing to see someone isn't a violation of those discrimination clauses. And all of those discrimination clauses, thankfully, include both sexual orientation and gender identity.
Absolutely. That's a great point. We did have a question in the Q&A from Dr. Amy Morgan. She says, incredible presentation. I really enjoyed it. What directions would you like the CFT, MFT field to move towards based on your findings and other research? And then a follow-up question, what actual steps are needed?
If I was going to think particularly, thank you so much for that question, Amy, and thank you for being here today. What a treat to have you in my audience. If I'm going to think particularly about the CFT, MFT field, I think the actual step and what needs to happen is we need to add a definition of a discriminatory referral to our code of ethics. So in the next round of the AMFT code of ethics, I've written about this. I'm working with a group trying to get this to happen, but I think we all need to be a part of raising up our voices. Our code of ethics need to define what discriminatory referrals are, and need to clearly define them in terms of clients' identity factors, that we cannot make referrals based on identity factors. A client can present with a presenting issue. Maybe I don't know how this could happen, but maybe I've never been trained on how to work with eating disorders. We've got a bigger conversation there to have, but let's say that happens and someone comes to me because they need help working with their eating disorders. That's an appropriate referral. But we need to have in our codes of ethics a definition that referrals aren't based on who a client is, but what they need help for. And so I think for both the CFT and for our field, for my field, or the field that I share with Amy, with the CFT field, we need to change but I think that's a call for everyone. I think our professional organizations can put out statements and guidelines and competencies, but it needs to be in our code of ethics. People need to lose their license or lose their membership in their professional association if this is a pattern of behavior they're engaging in.
Absolutely. So a couple questions just rolled in right after you answered that one. So Natasha Williams asks, is there a code of ethics from another discipline that has clearly defined discriminatory referral? Who's leading the way on this?
Excellent question, Natasha. Thank you so much. No, we don't see it hasn't made it into anyone's code of ethics. The strongest statement has come from the National Social Work Association. I think there are those of us writing about it, so I think there are ideas in the scholarly literature that could be cut and pasted into a code of ethics. But at this point, I don't see anyone leading the way in the code of ethics change, though I know I'm not alone in calling for it. And so I think it's about talking to the ethical. Most of our professional organizations have ethics boards within them, and reaching out and telling them this is what has to be in the next round. We're constantly revising our code of ethics. They're always being revised across disciplines, and so this is something that could be added.
Yeah, I think codes of ethics, we kind of see those as guiding documents, right? And so, if we look for guidance, that's where we need to go, and those things need to be kind of codified there. The next two questions are related to training environments and training programs. So I'll ask them kind of both, and I think they kind of go together. So thanking you for your presentation. What recommendations would you give current CFT students training in programs who have some growth to make in this area? How can students create change in their program? And then the second question is, what recommendations would you have for curriculum changes in training the next generation of therapists?
Wonderful questions. My hope is that faculty will talk about these issues. I know that I recently gave a guest lecture in a clinical training program. And what happened in that moment, the faculty were totally open and supportive, but they never had a conversation. They hadn't talked about, they talked to their students about referring when things are outside their competence, if you don't know something, but they hadn't talked about this. And I think, as sad, this may be not the most fancy answer you'll get, but I think we need to just start having conversations in our training programs about this idea, about, and even as you saw in my language maybe today, when I started writing about this, I stayed right with referring. I talked about this act of referral. More recently, I really think and write about it in terms of an act of refusal, because I think referring isn't fair, and I think it makes it seem more acceptable. But I think that we need to think about this as refusal, and who is it okay to refuse services to? And how did any of us get in this profession with the idea that we would judge certain clients worthy of services and certain clients unworthy of services? And so as silly as this sounds, I think starting a conversation about referral, and then we need to start talking about what is it, we probably do to steal the language from these bills. We need to talk about our deeply held beliefs. And rather, we as a clinician certainly get to have deeply held beliefs. I have them. I tell you about them if you want to know about them later. But how do they come into my therapy room? Because they will. Anything that, and I need to start engaging in really in-depth self of the therapist work. A lot of the self of the therapist work we do in our training programs is about learning about our family of origin and maybe some patterns within that family of origin. And that's valuable. I don't discount that. But we need to start interrogating these heterosexist and cissexist beliefs that we are raised in, that we are trained in, and really start looking at them. And so I think our self of the therapist work needs to shift beyond just understanding our family of origin to really understanding and exploring our beliefs and figuring out how they're influencing our therapy and whether we're okay with that. And even if we're okay with that, what are the consequences for our clients? And are we okay with our clients experiencing consequences based on our beliefs? And I hope we're not. And so I think it's about taking self of the therapist work in a really new direction and engaging students beyond and engaging ourselves beyond just who are our parents and who are our grandparents.
Yeah, and I think that also has strong implications for how we train clinical supervisors, even outside of training environments as well, to lean into those moments when you question, those things that therapists are bringing to them around issues of refusal. I love that language change. It reminds me of the language change we've also made around conversion therapy to change efforts, right? Because language is so important here. If I can just take a little liberty with asking one last question, because I think this is actually really critical with who's in the room. The question is from Amy Morgan again. Is there a movement within the QTAN group and AMFT, which is focused on, I believe, the Queer and Trans Network, that you can join efforts with on advocating for change at AMFT Code of Ethics? What are the things that folks can do? Because we do have a lot of particularly CFTs in the audience. What are things that they can do to get involved and help advocate for these changes?
Yeah, I think for the CFTs in the audience, if you haven't already and are able to, I would invite you to join QTAN, which is the queer interest group within AMFT. So it replaced the caucus we had for many years. So please consider joining it. And also know the power of your voice. I started talking with Dr. Fish about this as we were waiting for you all to join. Several years ago, a group of us came together because we really wanted a statement about those change efforts from AMFT, about ideally the unethicalness, I keep using that word, of the change efforts. And really, it wasn't a big group of us. We came together and we all committed. We talked about it at a conference, and then we all committed to sending a letter to the board, to the AMFT board. And I think not only sending a letter to the AMFT board, but also sending a letter to the ethics group as well, the ethics board within AMFT as well, telling them about your concern and telling them that this is what needs to be added. I also think when the next round, when we revise our code of ethics again, volunteering to be on that revision committee, know that I will be volunteering. Would love to have you all join, see if any of us can get selected. And then when there's opportunities for feedback, we need to provide feedback to them. But I think we could start now. Consider joining QTAN. And if you have time, send an email, send a letter to the board of directors and the ethics group telling them, and it can be simple, that you really want them to consider adding a definition of what a discriminatory referral is. You might have to explain them what a discriminatory referral is. I'd be happy to give you a couple articles you could attach to that email. And ask them, because I think it doesn't take a ton of voices within AMFT to start agitating for change. We just need some more voices.
Fantastic. Thank you so much. I know we went over a few minutes, but thank you so much for sharing your work with us, for sharing your thoughts on how to advocate on behalf of these issues within our respective professional organizations, particularly with AMFT. And I know you can't see everyone in the audience, but I'm sure there was a lot of gratefulness listed in the Q&A for your presentation. So thank you so much. Thank you to those who joined us. And we'll be posting the webinar online so you can share with others in your network so they can learn more about this. Thanks so much, Dr. McGeorge.
Thank you so much, Dr. Fish.